Dear colleagues, we are going to discuss today the following points of FH diagnosis. How do I identify patients with FH that are like at super high risk, the epidemiology of the disease, and how do we treat it? First of all, how we diagnose it. Actually, it's very simple. Even though there's a lot of mystery around FH, it's actually a very simple disease to diagnose. There are two ways, the Simon-Broom register criteria and the Dutch lipid clinic criteria in the next slide. The Simon-Broom sees the whole story of FH in a dichotomous way. Either you have definite FH or probable FH. Definite FH is if you have a patient that has a mutation in one of the genes that affects LDL metabolism, or a clinical thing, and I have to say, this is a personal preference always to a little bit the clinical thing. If a person has an LDL of more than 190 milligrams per deciliter, plus tendon xanthomas, I will show you what these are, or if his relatives have these bizarre xanthomas. And possible FH is if you have, again, please remember this number, an LDL more than 190 and family history of something, either family history of premature cardiovascular disease or family history of very high LDL cholesterol. The second one, diagnostic tool that we have, and much more widely used, I think, is the Dutch Lipid Clinic network criteria. This is very nice because you can put it in this, I have it saved in my computer, all my assistants also, in this FH score. So every risk factor for FH has a number, and then if you add up more than 8 points, you have FH. But if you have 6 to 8 points, you have probable FH. And the things that I ask my patients to figure out if they have it or not can be family history of cardiovascular disease or high cholesterol, clinical history, premature cardiovascular disease, physical examination, the famous xanthomas, or arcus cornealis, I'll show you a picture, and the labs, i.e., again, cholesterol. If you really have, for example, a patient with an LDL of more than 330, he has FH. And of course, the ultimate thing, very much loved by many colleagues, just a DNA analysis fact, a mutation in one of these 3 genes, LDL receptor, ApoB, or PCSK9. So anyway, please remember FH is a very easy disease to diagnose. Just think of 2 things, LDL more than 190 milligrams per deciliter and family history of something, hypercholesterolemia or cardiovascular disease. Or, of course, if you are lucky, you see these tendinous xanthomas. We don't see them that often. The most, I think, in my experience, the easiest way to find them is in the Achilles tendon, and you don't really, like, a person doesn't come in and has a huge thing in the back of his leg, but you have to, like, really touch it, and you can feel this accumulation of lipids there. And if you think something is here, you can always do an ultrasound. And this is the arcus cornealis. It starts like a little sickle thing. Oops. Anyway, I think you can see it where the arrow is, and the A on top, on the bottom, and then over the years it goes around your eye. This is lipid deposition in the cornea. The xanthelasma that you see in the bottom of the slide are very impressive, and they can, in a sense, guide you to, does this person have FH? But they are not part of the diagnostic criteria. But they are good suggestions to look further. In this I put, because, you know, we're talking about this LDL more than 190, please remember this number. The problem in real life is that your patients, like my patients, come to me with statins already on board. So this 190 can be washed out because they're already on Atorva 80. So this, again, this FH score thing that you can just save in your computer gives you a nice way, very fast, to calculate the pre-treatment LDL. So what I do is I put the LDL that my patient has coming in, And then you choose, oh, but he has this value while on atorva 40 plus ezetimibe. And then you get the value. And it's amazing what the difference is between the number that a patient comes in with versus what I see when I do a calculation of the real, without treatment, LDL. So when we diagnose a patient with an FH, it's recommended, and it's done, not by everybody, but it's supposed to be actually a good idea, is to try to find also family members that have this disease. And this is called cascade screening. You can do it simply with like LDL values, or you can do it genetically. If the person who is diagnosed has also a mutation, then it's really easy because you screen the other first-degree relatives for this mutation. Or how I do it in the clinic is based on LDL levels. So I tell my patient to contact his family members, and the ones that want to be tested, they come and are tested. And then if they are found to be positive for FH, then we test the first-degree relatives of this relative who is affected. And why do we care anyway about FH? What's the big deal? Well, the big deal is that these people are really ticking bombs for major cardiovascular events. You see in this paper that anybody who has just an LDL cholesterol of more than 190 milligrams per deciliter, if you compare them to the reference, which are subjects, the bottom part, with an LDL less than 130 milligrams per deciliter, they have a 6-time increased risk for cardiovascular events, even if they have no FH mutation. So just walking around with an LDL more than 190 increases your risk quite significantly. And what is amazing is that if you have an LDL more than 190 and a mutation, then you have a 22 times higher risk for a cardiovascular event. I.e., these are super high-risk patients, and that's why we care. So we established that they are really high risk. Can we fish out the ones that are like at super, super high risk in these individuals? And there are two ways to do that. One, I have to admit, I find this the way the HeFH risk equation a little bit more sophisticated compared to the next one, is that there are a number of parameters that you put in this risk calculator. Just copy this and put it on your computer. It's really so much fun. Every time you have an FH patient, I just put this data: age, sex, history of cardiovascular disease, blood pressure or not, high blood pressure or not, BMI, smoking or not, and LDL level and Lp(a) level, and then it just throws out the risk of this patient. So it's really nice because it helps you in the motivation to like maximally treat, because it shows from these very high-risk patients, these are at even higher risk. So parameters that matter is age, sex, history of cardiovascular disease, blood pressure, BMI, smoking, LDL, Lp(a). The other test, the other score is simpler, and it comes from not a prospective study like the HeFH registry, a wonderful registry from Spain of molecularly diagnosed FH patients. But it is also a nice thing. It's from a cross-sectional cohort study of patients with FH, and they found these 5 parameters to fish out the FH patients that are at highest risk: age, HDL level, hypertension or not, smoking or not, male or female. And they assign points to every of these parameters. And then they show very nicely, like the higher your score is, the higher is your risk to have a prevalent cardiovascular disease. So it's not prospective, it's prevalent cardiovascular disease. So if you are lucky and you are having a score of 18, I've printed this thing out and gave it to my team, then compared to the ones that have a score of more than 21, they have a 10 times higher risk to have prevalent cardiovascular disease. So just think, add these numbers, if you hit 20, then this person is very likely to have already cardiovascular disease. Now, this unbelievable, dangerous disease, how common is it? And it's actually quite common. I remember when I was in medical school, it was considered really an exotic, rare thing. Yet it's actually not. It's 1 in 200. So I'm sure many of us have these patients in our praxis. And this 1 in 200 was verified a couple of years later after this Copenhagen study that I showed you. And they studied 19 studies with more than 2.4 million people and found that the prevalence of FH is 1 in 250 individuals. So not rare at all, actually. So in the world, we have 34 million people with this disease. And what is really amazing is that more than 90% of them are undiagnosed. Because I know that some of you, or many of you here, are cardiologists, I want to show 2 slides that show that these patients are very common in cardiology real life. You see them a lot. There is an enrichment of FH patients in cardiology practice. Look at this study from Switzerland, where they found that in patients with acute coronary syndrome, the left part of the slide, the probable or definite FH is in 1.6% of the population. So actually 3 times more often than in the general population. And if you have patients with premature acute coronary syndrome, again, the left column, they have 5% of your patients that come to you with a premature coronary heart disease have an FH. And this was also shown in a very nice paper in Science 2 years ago. And they used the population from New Jersey and Pennsylvania, 50,000 people that agreed on being genomically tested. This is this Discover cohort. And they found that the prevalence of FH is 1 in 222, but in the patients that were coming from cardiologists, it was 1 in 100, actually. So think that you might be the first, the cardiologists here, that you might be the first people that actually see these patients, and you might be in this, in a sense, very responsible position to please diagnose these people, and then you can send it to us endocrinologists, and if you're too busy to deal with them. And how do we deal with them? How do we treat them? Well, as we said, even according to guidelines, these are very high-risk patients, so we have to get them down to an LDL of less than 100 if they don't have a cardiovascular event. Of course, if they already have cardiovascular event, to less than 70. And of course, we start with a statin. The key is, do statins work? Do they bring something to this genetically, in a sense, unlucky individuals? Yeah, they bring, and they bring a lot. As you see from this paper from Besselink and Jack 2 years ago published, they can decrease the risk of coronary artery disease and all-cause mortality by 44%. So diagnose them and immediately start them on a statin. High dose, it works. Of course, reality is always a little bit more depressing than nice papers, and this is a study from the Netherlands. This is a cross-sectional study, 1,200 individuals with FH, and they found that only 20% of the persons treated 27% on maximum dose statin and ezetimibe reached their goal of less than 100 milligrams per deciliter. Only 20%. And what I found, and I was really upset when I read this paper, the main reason why these guys don't reach goal is because the physicians are happy. In this study, the LDL was 125. The patients were, this FH patients, and the physicians said it's totally okay, no need. So we should all be more aware. And this is from the HeFH registry, again showing these extremely embarrassing numbers. Only 4.7% of the individuals with FH and cardiovascular disease reach their goal. And if you just have FH and not yet your MI, only 10% reach their goal. So we're really failing, there's no question. We are failing these patients, we let them die. So we need something a little bit like a bomb to help us decrease the LDL on these individuals. And the PCSK9 inhibitors, both alirocumab and evolocumab, can do that. We published a study in The Lancet a couple of years ago on patients with heterozygous FH. They either got placebo or evolocumab, 60% reduction, massive reduction, and not 7% or 5% reached their goal, but 70% reached their goal of an LDL less than 70 milligrams per deciliter. Oops. And the same is with alirocumab. They also did the FH trial. Again, about 70% decrease, 60% decrease in LDL, and about 60% reached their goal. So something we could never reach before, we can reach now. And this is exactly what the guidelines already recommend in these patients. Start with high-dose statin, add ezetimibe, and PCSK9 antibody on top to reach targets. And now 2 slides on real life, because of course studies are wonderful and everything looks better in a study than in real world. And this is from the Netherlands, from here. They examined FH patients, 65 genetically diagnosed, 14 clinically diagnosed, that received PCSK9 in real life, in a university hospital. And we see exactly what we see in studies. LDL is decreased by 60%, in both groups, and 60% of the individuals achieve their targets. Remember, until now we're talking about 5%, and now we're having 60% reaching their targets. And this is just from British Columbia. It shows the same thing. They compared 2015 to 2017. In 2015, we didn't have PCSK9 antibodies. 2017, we have. And they show that the persons that received PCSK9, 60% of them reached their goal. So this is not a local phenomenon. This is all over the world. PCSK9 antibodies decrease LDL cholesterol by 60% in FH patients and make them reach their targets. And again, I show this because, again, it made me upset. Why the patients, these FH patients, don't get PCSK9? 1/3 is because the doctor said, it's not necessary. So we should really work on increasing our understanding of the importance of treating these people. So I have just 4 little conclusion points. FH is the most common genetic condition that predisposes individuals to premature cardiovascular disease. And you cardiologists can be the first people that see these individuals. All FH patients are high-risk patients and need early and aggressive lipid-lowering treatment. Patients with FH are both underdiagnosed, massively undertreated, never or hardly ever reaching their LDL cholesterol targets, and now we are lucky enough to have 2 PCSK9 antibodies that help these unlucky individuals achieve their LDL cholesterol targets. Thank you for your attention.